You will learn how to examine sensory system examination. You can come forward. So sensory system examination in neurology. Okay. So when we talk of sensory system examination, we are examining which tracts. Okay. So as we know, the sensory tracts are spinothalamic tract. Okay. And the second is dorsal column or the posterior column. Pain and temperature is carried by the spinothalamic tract. Fine touch, position sense and vibration sense is carried by the dorsal column. And last but not the least, the cortical sensations mediated by the parietal lobe. Okay. And not to forget the primary sensory cortex is thalamus. And spinothalamic tract and dorsal column are ascending tracts. Okay. And cortical sensations are tactile localization, 2-point discrimination, stereognosis, graphesthesia. They are the basic 4 concepts of cortical sensations. So when we start examining the sensory system, we will first examine the primary sensation, that is pain and temperature, okay, and touch, pain and temperature. So we should know the dermatomal distribution on the patient's body. What are the dermatomal sensory innervations? Okay, the important landmark we should know: face is supplied by the trigeminal nerve. The sensation of face is supplied by the trigeminal nerve. There is a sensory division. This is the ophthalmic division from forehead up to the lateral canthus, then maxillary division, then the mandibular aspect. So face is by trigeminal nerve. And usually the face examination, that is the trigeminal nerve examinations, are done in the cranial nerve section. So when we have committed to the cranial nerve, we have done the cranial nerve examination. So sensory will start on the body. So the important landmarks of the dermatomal distributions goes like this. What are the hallmark we should at least know is the deltoid C5. This is the C5. Then this lateral aspect of the arm, forearm, including the thumb and index finger, is C6. From the middle finger, this strip is C7, and ring and little finger, this is C8, that is the medial aspect of the forearm. And when we talk of the arm, that is T1. So C5, C6, zoom, C6, C7, C8 and T1. The nipple area is D4, epigastrium T7, umbilicus D10, okay, symphysis pubis D12, inguinal ligament over the inguinal ligament is L1, this pocket area is L2, knee L3, coming to the medial part, this is L4, L4, come front, L4, the lateral aspect of the leg, L5, covering whole of the dorsum of the foot, excluding the ring finger, excluding the little finger. This is S1. So L5, S1, plantar aspect of the sole, that is the sole is S1. And when we go, थोड़ा पीछे हो जाएंगे क्या? उल्टा. So sole was S1, then this is S1 as a strip, as we know that these were L4, L5. So S1, S2, then perianal area S3, S4, S5. This is the dermatomal distribution. And when we start the sensory examination, touch sensation, we take a cotton and we have to talk to the patient first, make him understand. In neurology, that is the communication is most important. And in sensory system examination, it becomes all the more important because the sensory system examination is totally patient dependent. Whatever answer he gives, we have to go through his answer. So we have to make the patient understand what you are doing. ये रुई है, मैं आपको यहाँ लगा रहा हूँ, समझ में आ रहा है क्या? स्पर्श समझ में आ रहा है? स्पर्श समझ में आ रहा है आपको? तो अभी मैं आपको ये बॉडी पे लगाऊंगा, आंख बंद करना, जब जब भी लगा तब 1, 2, 3 ऐसा गिनना, ताकि मुझे समझ में आए कि आपको समझ में आ रहा है. टच है, बंद करिए. So the patient will close the eye. You have made him understand what you are going to do. Okay. एक दो तीन गिनना है जब भी लगा तो.
2 3 4 5 6 7 8 9 10 11 12 13 14 15 16 17 18.
So like this, we will examine the. He is understanding the pain perception. The touch perception is fine. Then we go for the pain sense. For pain, you have to use a common pin. Common pin. Stop. And you have to again talk to the patient, make him understand what is the pain sensation actually is. So this is the blunt end of the pin. This is the sharp end of the pin. मैं आपको थोड़ा एक पिन लगाऊंगा. चुभने जब चुभा तो बताना चुभा है ना. ये देखो ये वाला पार्ट चुभा क्या? ये चुभा. हाँ तो जैसे अभी चुभेगा तो बताना. वैसे आंख बंद करना, 1 2 3 गिनना है. आंख बंद करिए. माइंड इट, this is a dangerous issue because this is a sharp pin and we never know our movement, our hand movements, how much you are piercing. It can be really painful for a patient and blood can come out, it can pierce the patient. So there is a technique. You need not force the pin so vigorously so that it can injure the patient. So when you are testing the pain sensation, you can see your fingers should slide over the pin so that the pinch will be there and you are not going to hurt the patient. And again you can know that this can be a situation where diseases can be transmitted. Hepatitis B can be transmitted and blood-borne diseases can be transmitted. So you have to keep all these things in mind. So चुभा तो बताना. आँख बंद करिए जोर से. अभी चुभा क्या? अभी चुभ रहा है क्या?
नहीं.
हाँ. So when I am applying the blunt end, he is saying no. He has understood it.
No. 10 11 12
चुभ रहा?
15.
अभी चुभा?
नहीं चुभा.
जब चुभा तो सिर्फ गिनना. So pain is intact. So intermittently you will also apply the blunt end. You have made the patient understand that whenever there is a blunt end is being touched on the skin, there is no pain perception. He won't count anything. So when you are only piercing the patient, he is having the sensation and pain temperature is there. Pain sensation is intact. So whenever you are talking of temperature sensation, it is crude. In your examination, there won't be any burners or liquids or where there is a temperature is required temperature is again all are theoretical. What we can do is in quick clinical examination, we can ask the patient to touch a metallic object like the tuning fork, and usually this metallic objects are cold, and we will just ask him whether it is hot or cold. मैं आपको ये टच कर रहा हूँगा, ठंडा है कि गर्म है बताना. सो आँख बंद करिए, छू के बताओ ठंडा है कि गर्म है. So again eyes closed. This is cold. Usually the metallic objects are cold and he is perceiving it. So likewise in different areas, ठंडा है. So touch, pain and temperature. Then we go for dorsal column sensation, position sense and vibration sense. So how to test for position sense? थोड़ा सा ऊपर हो जाना है, थोड़ा सा ऊपर. For position sense, we have to first make the patient understand we are moving this great toe. We will be moving up and down, and first we will show what we are going to do. है ना? ये देखना इधर, ये ऊपर है, ये नीचे है, ये ऊपर, ये नीचे. अभी आंख बंद करके तुमको बताना है मैं ऊपर करूंगा कि नीचे करूंगा. आँख बंद करो. So the method of examining for the position senses, you have to grab hold of the grade 2 like this from the lateral aspect. Don't grab it like this. The lateral aspect, the base of the grade 2 you will touch, and in the second hand you will be touching the grade 2's upper part like this, and just after 2 to 3 slight movement you will make the patient. ऊपर है कि नीचे है? 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 ऊपर है कि नीचे? ऊपर है कि नीचे? ऊपर है कि नीचे? ऊपर है कि नीचे? अभी so the position sense is intact. Say for example the position sense is not intact, you can go to the upper limb also, and the same thing can be done like this. ऊपर है कि नीचे? ऊपर है कि नीचे? And when you ascend up, you can go for larger joint position senses also, like नीचे ऊपर, ask the patient to close eyes. If there is abnormal finding here, you can go up, and in the upper limb also you can examine the position sense. Okay. Sometimes actually what we did here is we did a passive movement and it got translated into position sense. So another way we can test for passive movement is we keep a particular arm or leg in a particular posture. Eyes will be closed and we will ask the patient to imitate the same posture in the opposite limb. That is also a position sense. Okay. आँख बंद करना. ये हाथ जैसे रखा वो हाथ वैसा रखिए. This is also one method to do for posture, the position sense. Okay. Then comes the vibration sense. We use the tuning fork, which is 128 Hz. That is the ideal tuning fork for examining the vibration sense. Again, ask the patient, you make him understand what is the vibration sensation, how it looks like, how it feels like. Okay. अभी मैं मार के तुम्हारे सर पे रखूंगा. You have to choose a neutral position. Either it can be the forehead or the sternum. Forehead is the ideal position. जब झुंझुनी महसूस हुई तो बताना. झुंझुन है, सिर्फ लगाने को झुंझुनी नहीं बोलना, ये लगाया है. झुंझुनी समझ में आ गई? अभी आंख बंद करना. तो झुंझुनी है? अभी है क्या?
नहीं.
अभी झुंझुनी है क्या?
नहीं.
अभी है क्या? अभी?
नहीं.
So intermittently you are making him understand what a real vibration sense is. You are catching hold of the tuning from stopping the vibration sense. He got it. He said no, there is no vibration sense now. Now you can go ahead on the body. So ideally you will start from the lower limbs and you have to put the tuning fork on the bony prominences. Okay. So what are the bony prominences? The base of the corrector, medial malleolus, lateral malleolus, shin of the tibia, patella, anterior superior iliac spine. Then on the fingers you can go. Okay. So bony prominences. Remember one thing, when you are going like this up, patient is saying no vibration sense, no vibration sense. In the anterior superior iliac spine also there is no vibration sense. Then you have to test the vibration from the posteriorly on the spinous processes, because you have to go structurally, that spinous processes. Then you come to the upper limb. So dorsal column sensation we are testing, vibration sensation. झुंझुनी महसूस हो रही? हो रही? हो रही. अभी? Sometimes the examiner also puts his finger down the base of the toe, because through his bones I am also getting the vibration sensation. So in one way the examiner is using himself as a control, so that he is feeling till the time the vibration is ongoing, patient is also feeling the vibration, I am also feeling the vibration. Okay. आँख बंद करना. So vibration sense is intact. Okay, the dorsal column. So after that we will be coming for the cortical sensations. Okay. So in cortical sensation, 2-point discrimination. tactile localization, 2-point discrimination, stereognosis, rapid. For tactile localization, the same thing we can do. We can use our fingers also or the cotton. Now, the difference between the sensory test we did in the spinothalamic sensations, that is touch sensation. Okay, we are using the cotton like this. Here you have to keep the cotton in a particular point and the patient will locate exactly where you have put the cotton. Okay, तो मैं अभी ये रुई कहीं पे रखूंगा, या तो हाथ या तो उंगली या तो कहीं रखूंगा, तुम दूसरे हाथ में बताना एग्जैक्टली कहाँ पर रखा, समझ में आया? आँख बंद करो, दूसरे हाथ में रखो, दूसरे हाथ में बताओ पॉइंट करके, दूसरे हाथ में, मैंने ये हाथ में रखा है ना,
ये वैसे बताओ।
हाँ, ये हाथ में पूरा पॉइंट करो कहाँ पे रखा है मैंने। हाँ, so he is pointing. So there is tactile localization. He is locating. Okay, this is cortical sensation. Don't confuse it with normal sensation of spinothalamic tract. Okay, tactile localization. And what is the important rule here? The important rule here is cortical sensations will only be tested when the spinothalamic sensations are intact. If spinothalamic sensations are not there already, there is no meaning to test these finer sensations which are mediated by the cortex. So that is the rule, thumb rule. Okay. So tactile localization is present. Then comes 2-point discrimination. For 2-point discrimination, you have to take a divider which is having the blunt end, or 2 pins can be used. Is having a blunt end, because if it will be a sharp end, you are testing pain again. So blunt end, 2-point discrimination. So we will be keeping these 2 points, and the patient should know that whether at 2 different points he is perceiving the dividers 2 different points, or he is not perceiving as only one. The clinical significance is, if you remember the sensory homunculus, that is the body parts representation of the sensory part of the body in the brain, in the parietal lobe. There, the finer areas like lips, thumb, they occupy a larger area, and the trunk, limbs, this crude, which is seemingly larger morphologically from outwards, in the brain the representation is very small areas. So here is the most important trick. So going by this rule, the finer sensory areas of the body like lips and tips of the finger, the patient will pick up lesser distance, like 2 to 3 millimeter. Okay, and for the broader parts, you have to make the divider more open so that he can perceive that there is 1 or 2. मैं अभी आपको ये लगाऊंगा, एक जगह पे समझ में आ रहा है कि 2 जगह पे समझ में आ रहा है, बताइए, है ना? आंख बंद करना। एक जगह पे टच किया है कि 2 जगह पे टच किया, बताइए। 2 जगह पे, saying 2, हाँ?
2
He's saying 1, 1. Okay. 1 he's saying. मास्क खोल सकते क्या थोड़ा? आँख बंद करो।
2 जगह।
2, उठ के बैठा ना थोड़ा। एक या 2? 1. He is saying 1. So you should not do like this. This is not an abnormal finding. Now I have to open it up little bit. 5 to 7. अभी कितनी जगह पे रखा है? 2 जगह पे, 1 जगह?
एक ही जगह पे।
अभी
2 जगह पे।
अब 2 जगह। अभी
2 जगह पे।
अभी
1 जगह पे। 2।
So while testing on the back and trunk, open it up. Okay, 5 to 7 centimeters. Okay. So 2-point discrimination. Then comes stereognosis. You have to give something in the patient's hand and the patient identifies the structure. Okay. Say for example, I will give you something like आंख बंद करिए, मैं आपके हाथ में कुछ दूंगा, क्या है आप बता सकते तो बताना. आंख बंद करो.
पेन.
Key. So this is stereognosis. Then comes graphesthesia. Graphesthesia, again I will write something on the patient's palm, and whether the patient is identifying it, that depends on the literary level of the patient also. You can draw simple diagrams also. मैं अभी आपके हाथ पे कुछ लिखूंगा, ABC समझ में आता है ना, तो कुछ लिखूंगा, क्या लिखा आप बताना. आंख बंद करिए.
ए. तीन.
क्या बनाया मैंने?
0.
So graphesthesia is intact. So this is the way we examine the sensory system. Okay. Now briefly talking about what are the different patterns of sensory loss. Let जाइए. So just briefly I will mention, there are a lot, but what are the important patterns of sensory loss we will just discuss. We will go from above downwards. Say there is a lesion in the parietal lobe. So if there is a lesion in the parietal cortex, the person will be having contralateral loss of cortical sensations. There will be loss of contralateral cortical sensations. If there is a lesion in the, say for example, left parietal cortex, tactile localization, two-point discrimination, stereognosis, graphesthesia, contralateral will be gone. Then we come to thalamus. In thalamic lesions, there will be loss of contralateral sensations involving the face and the body in the same. Contralaterally, it will involve the face going down to the body. So one half of the body contralateral to the lesion, including the face, there will be loss of sensations. Okay, judgment temperature sensation will be lost because thalamus is the primary sensory cortex. And sometimes a syndrome which is known as Girin-Rosse's thalamic syndrome, where after a thalamic infarct or hemorrhage, the patient survives, then there is a excruciating pain in the region involving the face and contralateral body. Okay, a very, very painful positive sensory phenomena. Okay, this is thalamus. Okay, then we come to the subcortical area. Okay, subcortical area again same, contralateral pain and contralateral pain temperature sensations will be lost. Now we come to the brainstem. In the lateral syndromes of the brainstem, if there is an infarct or lesion in the brainstem, in the lateral aspect, that is the lateral medullary syndrome, lateral inferior pontine syndrome or lateral medullary syndrome, what will happen is in the ipsilateral side, there will be loss of facial sensations, pain temperature sensations in the face, and in the contralateral side, there will be loss of spinothalamic sensations. So ipsilateral pain and temperature of the face with contralateral on the body pain temperature sensation is gone. That is, say for example, lateral medullary syndrome of Wallenberg. Along with other clinical features, we are talking only on sensory, so I won't talk about other features. So this will be you will identify that it is a brainstem lesion, ipsilateral face with contralateral body, loss of pain temperature sensation. Okay. Then crudely when we come to the spinal cord, we know that there is intramedullary cord compression, extramedullary cord compression, and as per the sensory fiber arrangement from medial to lateral, cervical, thoracic, lumbar, sacral. So if there is an intramedullary cord compression, the cervical fibers are getting affected, then thoracic. So it is going on like this. So intramedullary cord compression, like a prototype syringomyelia, we will be getting a hanging anesthesia because cervical fibers, there is somewhere sensory loss here. Cervical, C2, C3, C4, C5, C6. So a examiner can miss if he just goes for examination like this sensory. There is a hanging patch of anesthesia here, you are missing it. So intramedullary cord compression, there is a hanging anesthesia. And here, the pain and temperature sensation will be lost. But when you go for the position and vibration sense, it is intact. This is also known as dissociate anesthesia. Preservation of the dorsal column sensations with loss of spinothalamic sensation. Because the spinal cords are crossing just above the central canal like this, and here is a lesion which is extending like this. So this is dissociative anesthesia. These two important points you should remember. And there is always sacral sparing. Usually the sacral sensations are intact because sacral fibers are the outermost, and here our lesion is growing from inside out. So three keywords for intramedullary cord compression as far as sensory is concerned: hanging anesthesia, dissociative anesthesia, and sacral sparing. Now if we discuss an extramedullary cord compression, just the reverse. There can be early sacral involvement and there will be ascending anesthesia, and sacral involvement is there. So roughly speaking, these two conditions in spinal cord one should remember. Then in spinal cord, if we go for a transverse myelitis, whole transverse section of the spinal cord. If there is a whole transverse section of the spinal cord, remember the rule: below the lesion, there is loss of all modalities of sensation. There is a sensory level. So you will be getting this keyword is sensory level. There is a sensory level on the trunk below which all modalities of sensations are lost. And at the level, there can be hyperesthesia. Because of the root compression, there can be hyperesthesia. Okay, so this is spinal cord, and apart from that, there will be motor weakness also. We are sticking to sensory. Another condition which is known as hemisection of the spinal cord, that is the Brown-Sequard syndrome. It can be an early manifestation of an extramedullary cord compression, which is extending from the vertebral column compressing the spinal cord, or a neurofibroma or schwannoma or something, meningioma, which is compressing from outside. Earlier stages, it is a hemisection. Later on, it may progress. So hemisection of the spinal cord. What is the clinical trick to diagnose hemisection of the spinal cord? Because we know that if this is the side where hemisection has occurred, so you may get a sensory level. But the dorsal column sensations will be gone ipsilaterally, and the spinothalamic sensation will be gone contralaterally, because the spinothalamic tract is crossing at the level of spinal cord to the opposite side. So same side you will be having the dorsal column sensory loss, contralateral side you will get pain temperature sensory loss. So this is the Brown-Sequard syndrome. Okay. Then after that, in the spinal cord we come to the peripheral nerves. So in peripheral nerves, even in spinal cord, one can again stick to a little bit more discussion. That is the Cortical syndrome or Cortical syndrome. Remember, always there is saddle anesthesia. There is a saddle anesthesia in S2, S3, S4, or S4, S5, A3, 4, 5. There is a sacral sensory loss. And now, how to differentiate between the sacral sensory loss and the extramedullary cord compression, which we told, we discussed the early sacral involvement is there. From that, Cortical syndrome. That will be the predominance of lower motor neuron signs. There will be variable wasting, atrophy, loss of reflexes, asymmetrical versus symmetrical, absent knee jerk or ankle jerks are absent. There will be wasting, gluteal atrophy would be there, and your sacrally mediated reflexes like bulbocavernosus, sacrococcygeal reflex, anal ring reflex, S2, S3, S4, all these guided, these reflexes will be lost, and you will be having sacral sensory loss in a saddle distribution bilaterally symmetrical. So again, the keywords for Cortical syndrome: saddle anesthesia, lower motor neuron signs, hypotonia, variable wasting, areflexia, plantar subflexor or mute. Okay, with sacral sensory loss will be Cortical. Okay, so now coming to the peripheral nerves, peripheral polyneuropathy, globe and stocking anesthesia. So there will be the sensory loss will be from pain and temperature sensation will be lost. Sometimes position vibration also, depending on which fibers are getting involved. Motor sensory, all can be getting involved. So there will be a graded bilaterally symmetrical tingling sensation or numbness, dysesthesia, pain will be there on clinical examination. There will be loss of sensation will be there. It will grow up like this. Once it reaches the knee, the tingling starts in the fingers, because these are length dependent. Polyneuropathy is length dependent. So whatever the systemic causes are there, whatever there, this is the glove, and stocking. Rather, it should be stocking and glove anesthesia. It starts as a stocking, then glove anesthesia. This is where we discussed briefly what are the different patterns of sensory loss.